Good morning, everybody. We had clinical examination again on the 6th, I remember, elbow course. And at this time, Savas had a very good idea about watching together a video of clinical examination and make some comments on that. So Savas sent me this nice video. I think almost all the tests are there, so can we show this video, please? Of course, history before clinical examination is crucial. Work-related injuries, operations before, some other pathology on the elbow or around elbow, pathology on the shoulder, on the cervical spine, on the hand. Everything is crucial, and that's why elbow is a part of the upper limb. And this is nice to know about upper limb pathology and clinical examination, and of course, related operations. So this is the video. Okay, so in inspection, it's easy when you ask the patient to move the elbows, flexion, extension, and when you have the elbow downside, okay, and this is supination extension, and it's nice to go with the elbows in the body, because if you use the forearm, you don't have the exact supination and pronation of the wrist. Sometimes you mix that. So you can have a nice view there. So palpation of the epicondyle, medial side, olecranon fossa, palpation of the tendons, and of course, you see some scars if you have a previous operation or if you have an arthroscopy. It's nice to go and mark the spots, the portals of the arthroscopy or the incisions, because it's very crucial for the next operations. And this is the lateral part, epicondyle, and humerus condyle, olecranal, and radial head. And this is the soft spot when you have some infusion or edema there. So it's nice to see, and very crucial, the lateral side. And of course, you have to check the hand. We know about the nerves. So some specific tests. Ulnar stability, posterior artery instability, plica impingement, radial head, radial and ulnar epicondylitis, ulnar nerve, and tendon pathology. So we see now in this video some of these tests, and we start with the medial instability. This is for the medial complex. We heard before about the medial complex. So ulnar instability. One of them is the valgus stress test. The other is the milking maneuver, and the other is the moving valgus stress test. There are more tests, but I think these are important and significant tests, and I think are quite enough in order to check the medial instability. When you go in extension, we know that the bones there, they don't let any medial valgus stress. So you have to do the test, this valgus stress test, not in a full extension, but in about 30 degrees of flexion, because then you remove the osseous integrity and you check the tendons and the ligaments. So you move there. This is on a semi-pronated position, and you have some pain on the medial side. This is the milking maneuver. The patient is sitting there. The thumb is grasped by the examiner. You feel the internal epicondyle, the medial epicondyle, the medial complex. The patient have pain when you move, when you stretch in a valgus position. And when you move the elbow during flexion and extension, you have the same test, but a dynamic way. And this is called the moving valgus test for the medial epicondyle. You have pain in this range. O'Driscoll described that. And these are quite sensitive and specific tests for the medial instability for the lesions of the medial complex. You have some kind of apprehension. Sometimes the patients, they feel uncomfortable. Some patients, they feel pain when you palpate there the medial complex. They call it shear angle and shear range. Shear angle is the angle when you have pain. I mean, I have pain in 80 to 40 degrees. Yeah, and the shear range is the range when I have the maximal pain. This is a way to communicate with other doctors or to communicate with your file when you see these kind of patients. Posterolateral instability. Stand-up test, posterolateral apprehension test, posterolateral rotator drawer test, push-up test, and tabletop relocation test. These are tests about posterolateral instability. It's not an easy case. It's not a clinical case. It's not a surgical easy case. The patient, you ask the patient to stand up. They sit in a chair, stand-up test. So by axial loading the elbow in a supination position, they feel some pain before the full extension, or they know there is no way to stand up, and this is a positive test. Sometimes you say to the patient to stand up, and he cannot stand up. So this is a positive test for this patient. And this is the push-ups. This is a modification. You can do it also in the ground, but this is a different angle. You see the supination of the forearm, full extension, and the patient goes in the middle flexion about 90 degrees. So the positive test here is if he cannot do this kind of test, or he feels pain on the lateral aspect of the elbow. And this is the top relocation test, 3 phases. The hand is on the table, away from the body, supination position, extension, and then goes in a middle flexion, about 70 degrees. Then he pushes, the second step, he pushes with the elbow the table, and he feels some pain there. In the third phase, he pushes the table, and he's doing some more flexion, and also feels pain if it's positive. And the relocation test is, you see now the examiner, he pushes the radial head on the place, on each anatomical place, and the patient feels no pain. This is also a positive response for this kind of test. This is a relocation coming test from O'Driscoll, and this is a quite positive patient in awake patients. This is crucial because the patient is awake now, is not in sedation. So you see the pain there. He relocates, she's doing the same test, and the patient feels no pain. So this is a positive test for posterolateral rotator instability. Yeah, you see the soft spot, you see the radial head there. Okay, so this is also the apprehension test. This is for posterolateral instability. We're on the apprehension test. Sitting position, the patient on full extension of the elbow, the examiner grabs in supination with axial loading and valgus stress. She's on extension, she goes in the middle flexion about 40 degrees, and if there is a true posterolateral instability, there is a subluxation of the radial head. This is a sensitive test in awake patients, but it's more sensitive in patients that they are in general anesthesia. It's more sensitive, about 100% sensitive in these kind of patients. So you flex there in about 40, 70 degrees, you have this instability. If you flex more, then the head goes in the anatomic position. This is the posterolateral drawer test. This is something like Lachman for the guys that are doing knee surgery. They keep the humerus there. The other hand is on the adibrachium of the radius, pulling posteriorly the radial head, the adibrachium. And by this position, you have a translation of the whole adibrachium on the pivot of the medial collateral ligament. That means that the medial collateral ligament there is okay, the lateral collateral ligament is missing or defected, and the whole adibrachium comes around as pivoting on the middle glenoid. And this is the grip pinch. We have this in several examinations also in hand, in wrist. You grasp, and you see the rotating on the arthroscopy side, pivoting from the middle glenohumeral ligament. This is close. This is, I think, clear. And there's this patient is going for an open reconstruction of the lateral ulnar collateral ligament. Osteochondral defects. Yeah, osteochondral defects. The examiner putting the finger on the lateral side. Most of them are coming from the brachial condyle, lateral condyle. There is an active flexion, extension, active supination, pronation. You see there, and there is some pain on this kind of region on the lateral side, on the lateral epicondyle, and most of them in the lateral, in the extension of the elbow. I mean, in the maximal extension, most of the times you have more osteochondral lesions. Epicondyles, very common in your examination when you examine elbows. Lateral epicondyle, Cosen test. This is the positive with pain over the fascia of the external carpa radialis when you have a resisted wrist, or the Maudsley test when you have resisted middle finger extension, also pain over this fascia coming from the external carpa radialis brevis. And on the other side, on the medial epicondyle, resisted flexion is a reverse Cosen or the Mills test. On the same way, you have pain on the medial epicondyle, medial condyle during resisted flexion. This is a resisted supination coming pain with the flexors. The plica impingement, you have two kinds of plica, the dorsal and the ventral, or the posterior and the anterior. The patient is grasping on the dorsal side on the soft spot. There is an extension, almost full extension, active one, and sometimes you have pain there. Maybe you suspect of a plica, and this is on the other side with flexion and pronation, and maybe you have a plica on the anterior side. Plica is intra-articular lesions, and very rare. You can see also during inspection. This is the plica, as the examiner said, in the anterior part. You see there some grasping there, some snapping there from the plica on the anterior side. And of course, the ulnar nerve. We have the ulnar instability. Sometimes you have to differentiate with the triceps snapping on the medial side. It's very close there. So you have to palpate the ulnar nerve in the cubital tunnel. It's very crucial for arthroscopy, for previous surgeries. And this is a dislocation, a subluxation of the ulnar nerve, you see there. And sometimes you have to differentiate with the middle side of the triceps. Yeah? And of course, the sensation, the sensitivity coming from the ulnar nerve, you know, the small and the ring finger, these the 2.5 surfaces. On this region, the strength of the interosseous and the abduction of the fingers and the thumb. Distal biceps tendon, hook test, squeeze test, lag test. This is for the complete tears, and the resisted supination test. You keep the patient in an elbow flexion 90 degrees, close to the body, supination, and the figure of the examiner goes from the lateral side in order to grasp the tendon coming under the tendon, in order to pull this tendon. This is called the hook test. If the biceps is not there, you don't have anything, you just pull it there and you don't find a tendon. And this is a squeeze test. This is also for the triceps. This is also like the Thompson from the Achilles tendon. You see the examiner squeezes the biceps, and he's trying to see some motion there. You see some motion, especially of supination. Biceps there is a strong supinator muscle. Supination is crucial. And when you supinate your wrist and you go for the resisted supination with 90 degrees flexion and you have some pain, maybe partial tears are there. not complete, but partial tears are there. And partial tears are not very rare, maybe are often in this kind of lesions, and you have to differentiate. And this is the well-known lag signs. Lag signs, we have almost all the regions, we have tendon tears, and you see the lag that coming from the complete tear. And of course, when we examine an elbow, and of course it's most crucial in fractures in elbow or post-fracture cases, you have to examine also the distal radioulnar joint. We know for the S-extraopresty lesions and the instability of the distal radioulnar joint. And of course, clinical examination comes with other examinations we discuss later, like fluoroscopy, especially during operations. Ultrasound is so useful for everybody, and we'll have, I think, a talk for an expert in ultrasound. And I think now clinical examination and with some correct examinations coming from MRI, ultrasound, OCT, we have an arthroscopy, of course. I think we do almost 100% specific and sensitive diagnosis. Thank you very much, Savas.